Good evening, ladies and gentlemen, and to everyone who's watching us live from various parts of the world. My name is Ruben Lobo, and on behalf of team DentistChannel.Online, I warmly invite you to the fifth day of the biggest virtual implantology event of 2020. Ladies and gentlemen, we have with us Dr. Shlomo Birshan, who would be talking on the mono implants manufactured by Norris Medical. Ladies and gentlemen, a short introduction about our next speaker. Dr. Birshan completed his DMD degree at the Tel Aviv University with honors in the year 1998. He received his hypnosis license in the year 1998 and is licensed to perform dental treatments under general anesthesia in the year 2005 from the Israeli Ministry of Health. Dr. Birshan has won various awards during his career, such as the IADR Young Dentists Award in Vancouver, Canada, and in 1999 for presenting his DMD thesis. He is a diplomate of the ICOI, expert in oral implantology from the DGOI. He has presented various lectures as well as complex cases, including live surgeries on worldwide congresses. Dr. Birshan is a clinical instructor for Norris Medical. Dr. Birshan has multidisciplinary private practice and has an operating room where he performs dental implantations, ancillary procedures, complex augmentations, and rehabilitations. Ladies and gentlemen, presenting to you Dr. Shlomo Birshan live.
Okay, the screen is, can you see it? Okay.
Yes, sir.
Okay. Hello, I'm going to talk today about the mono implants. And we have actually a short lecture. So I would present the implant first, and then I will speak of clinical cases. Now, I'm not intending to show you most of the cases like long-term, because actually I want to show you as much as possible cases. So at the end of the lecture, you will be able to use the implant by itself. So monolithic implants are actually not new in the market. We had it for many years. What we had, our limitation was that we could not actually change the angle of the implant after putting it. Here we have a unique neck for the implant that enable to change the degree of the abutment after putting the implants or while doing the prosthetics. Now, as you can see here, we will talk about the diameters, but anyway, the implant comes up to 18 millimeters length and up to 5 millimeters width. So the implant, when it was invented as a monolithic implant, it was invented for narrow ridges. But here we can use the implant, as you heard, if we have it from 3 millimeters up to 5 millimeters. So all cases are indicated. And when we can change the angle, actually this implant is indicated for all type of cases. So if we will compare between a regular implant and the mono implant, we can see that the mono implant is narrower throughout the entire length of the implant. It does mean that usually if I'm using 3.3 or 3.75 millimeter in the upper jaw, I'm using only the pilot drill for that. So it's very easy. Also in the lower jaw, like I'm using the 2, maybe 2.4, and that's it. So very, very easy to place. The implant is, of course, self-tapping. It condenses bone, very high initial stability. And of course, this implant was made and done for immediate loading. So, of course, we have the drilling protocol. I advise you at the beginning to stick to the protocol And by doing more and more implants, of course, you will have and you will develop your own protocol. So what do we have? We have regular monolithic implants. Here you can see from 3 millimeter diameter to 5 millimeter diameter. Now, the important thing here is the D2. The D2 is actually the diameter of the length of the neck of the implant. Now, in order to be able to bend the implant without harming the bone or the implant itself, the width of the neck shouldn't exceed 2 millimeters. So it means that implants 3 millimeters and 3.3 millimeters, you can always bend by definition. But what about 3.75 and 4.2? For that, we have a special line, which is called bendable mono. And for that, you can see that the D2 is actually 1.8 millimeters. So in order to compare, here you can see that in the regular mono implants, we have 2.5 and 2.8 for the neck in regular implants, and from bendable mono, it's 1.8. 5 millimeter implant, by definition, are not bendable, but they are rarely used, and you can understand why. Here are the mono components. Here I wanted to show you the analog and the transfer. If you didn't touch the abutment, you have some keys in different lengths. If you are between two long teeth, you will need the long driver, for example. And you have, of course, a marking drill for those who want to use it prior to using the pilot drill. So I'll show you some cases of long-term follow-up, because we all know that monolithic implants work better than regular implants because there is no gap between the abutment and the implant. So while they succeed, they stay for many years. So we know that. Just wanted to show some cases. This is a case that was done 20 years ago. Here you can see the silk sutures that I don't use many years ago, metal framework, X-ray, final ceramics, and final restoration. This is a 16 years old case to 3 implants that were done in order to replace teeth number 42 to 32. So here you can see the teeth, and here you can see the final work. By the way, I think that it's a great challenge to create nice teeth in the area of 42 and 32. Here my technician was very creative when he did that. So this is how it looked today. Almost no bone loss. Another case, my patient, she did the case in 2004, and I think that after 2 or 3 years, she just disappeared. She returned to me 2 years ago, I think. She said, the implants that you did to me are a little bit painful. So this is how it looked today. Now you can see that because she didn't go to the hygienist, she lost some bone, but still 16 years after, without any maintenance, I think it looks quite good. So here are the implants. Here is the final restoration, and here we can see how the patient came, how the gums look. But if we compare it to 16 years, it looks completely not bad. So what I'm going to show you now are cases from the last 3 years. Part of the cases will use, of course, bendable. Part of the cases, there will be regular mono. I'll show you all. This patient came with tooth number 22. He broke the tooth. I just extracted the tooth and placed immediately an implant in the socket. So what do we have to do? Bend it a little bit so it will go with the arch. This is how it looks after the bending of the implant. This is a temporary crown which I created in the clinic, and this is the temporary crown. Here you can see that here I combined cortical implants and mono, but here I want to show you tooth number 21. The patient broke the tooth. This is the implant that I did immediately. This is the broken tooth. This is the implant. And this is the temporary crown. This is how the final crown looks 4 months after the implantation. And here is how it looks in the X-ray. So here I want to show you a short video. How do we really do that? Now you can see how do I bend the implant very, very easily. As you can see, the neck of the implant is relatively narrow. And again, note how do I bend it. Do you see how easy to make it? And another case. And note how the implant go fast in. Here I have to do a minor correction with the abutments. Here you can see very easily I bent the implant toward the other implant. And now we developed also a new type because we don't want to create a real pressure on the neck of the implant. So we created a new key and a new implant. Now I'll show you the video and then I will explain you what is going in exactly. So one of the problems is that if you bend the implant too much, you can theoretically break its neck. So now we have a special hex on the implant itself. So now if you broke the neck, you can take out the implant very easy. So this is what I wanted to show you. Now this is the implant carrier. This is the new key. Now the new key catches the hex and catches the abutment. It does mean that if I want to bend the abutment, I won't create any pressure on the bone while doing that. So this is the new generation of the bendable mono implants. You can see no pressure on the bone. I want you to see how much I can bend the implant. It is a very special technology that really lets us do that. I'll show you another video for that. You will see the extreme angles that we can get. Here in this video, I want to show you also that if you want to put the neck below the bone, nothing happens. You can always use or the conventional carrier or the key itself, but not use the hexed part of the key. So here, as you can see, we went just into the bone with the hex in order to show you that nothing happened. You can bury the hex into the bone and then take the conventional key. See how much I can bend the implant. Easily bend it. So another case, tooth number 43. I'm going fast because I have a lot of cases and a relatively short time. Again, I can bend the implant very easily. By the way, I was asked, what happens if you have a single implant and you bend it? Nothing will happen. While you put it right in place, no, if the occlusal contacts are correct, no problem with that. It has never changed angle after doing the prosthesis, the final prosthesis. Here you can see bended the implant, temporary crown. Now, I think that this is the really, I think that this is the extremist that you can do with a narrow implant. And this is a patient that did an orthodontic treatment, and the orthodontic treatment did not succeed. And she came to me and she told me, listen, I don't want to continue with orthodontics. She's 18 years old, and she wanted me to give her a solution. Well, I gave her a solution with a mono implant. It's very difficult to do without harming the adjacent teeth. This is how she looks. As you can see, she doesn't have a canine. So I don't know how, what was the logic of this orthodontic treatment. She is 18, and I had to give her a solution. And I didn't want to prepare adjacent intact teeth. So this is the implant. I bent it as much as I could. And of course, I have to place it now. See how much I bent it? Then I trim the abutment so it can fit to the occlusion. And this is a temporary crown. And I think that the result is very nice and very fast, because in 20 minutes, the patient had a solution. Another case, tooth number 11, the patient came to me. Actually, this tooth is periodontally, endodontically involved, so it is a hopeless tooth. So the patient really wanted to save his tooth. So what we did was extracting the tooth, putting the implant. In this case, I didn't have to bend it even. And what I did is, instead of doing a temporary crown, what I did was to cut between the root and the crown of the tooth, and then I prepared the inner part of the tooth, the original tooth of the patient, put a little bit of acrylic, really a little bit, and this is the final temporary result. You know, after a year, I didn't want to keep it like that, because actually it doesn't really fit as I would like it to fit. So we did the final zirconia crown. And this is how it looks. Another case with the patient own tooth, put the implant, bent it a little bit, and used the patient's own teeth in order to do the prosthetics. In this case, the patient just stayed with this tooth. She wanted also to reduce her costs. And this is how it looks. And it looks very good today also. Here, tooth number 13. Again, most of those cases, they just appear in my clinic suddenly, and they expect me to give them fast solutions. So this is how it looks. And this is the tooth. This is the implant. I didn't have to bend it. And this is the crown. By the way, by definition, especially with single implants, if I can put the implant initially in the correct direction, of course I would do that, and I would prefer to do that. But I always put the implant in the best place concerning the bone. The prosthetic will always have to adapt itself to the situation of the bone. Here, teeth number 14 and 15. Here I wanted to show you, for example, how do mono implants unbendable, regular they look. Here you can see that the neck is very thick. So I hope that it's clear for you that in these implants, of course, you cannot bend the implants. Okay, so these are the extractions. Implantation. Here, as I told you, I cannot bend them, so I put them just in the correct direction, yeah? And this is the final temporary crown, and this is the final zirconia cases. And of course, with the final, I also did the composite restoration. Here it is how it looks. Teeth 42 to 32, regularly we place 2 implants for 4 teeth. Here it's how it looks. So I extracted the teeth. As a rule, if I'm doing immediate implantation, I always try to extract the tooth and to avoid flap opening, because the best way to preserve a papilla is to just to leave it as it is, because when you open a flap, you cannot assure that you will have the papilla in place. Okay, so these are the implants. Here I put this implant a little bit toward 31 because the bone in the area of 42 was very weak. So these are the implants. They are unbendable. Again, I want to show you how do they look. Temporary bridge and final bridge. Here, extracting of teeth 24, 25, and 26, and immediate loading, although the implants are the teeth are very, very near to the sinus. So these are the implants, as you can see. Here I did a little sinus lift, and actually here you can see the implants, and here you can see the temporary bridge. This is how it looks from the inside, and this is the video. as you can see, the concept of narrow ridges, narrow implants, as you can see, although these implants are monolithic, they can be used for a wide range of indications. So this is how they look. And I think it's quite nice. Here I want to show you shortly how do I prepare the abutments if it's not in the occlusal plane. If I prepare the implants, I usually do it with a carbide burr. Now, we know that titanium parts do not harm the bone, so they can serve as bone substitute, so they do not really harm anything. So we can prepare it just like that. So this is a carbide burr. I always prefer a carbide burr because it hits less the bone. And here I can check the occlusion. What about big cases? Big cases also can be done because we can change the angle of the implants. We can count on bigger cases. So in this case, this is a 130 kilogram patient, and he really scared from dentists. Well, I was lucky that he came to me and I had a little bit of time, and he told me, do you know you can extract only tooth number 22 because I have pain. I don't mind to stay like that. I told him, do you know what? I'll do everything in 1 hour, and I promise you that in 4 hours you will get a temporary bridge from the lab. And this is what I did. And he agreed, because when the patient comes to you and you do the procedure, this is the only way to assure that he will sit with you. Because when he do his meeting with you, and then he is afraid, and then he cancels the meeting. So of course you will have the best chance to sell it or to do it when you can convince the patient immediately do that. Okay, this is how it looks. I think that not bad at all. This is his teeth. This is the temporary bridge that I promised him. He went out of the clinic with a temporary bridge. And this is the metal framework after 4 months. It's very good. And this is the final result. And I think that it's a quite satisfying result for a case that was done in 1 hour. Also, here I want to show you that when we bend the implant, sometimes we bend the implants in order to avoid the mental nerve. And this is what I did here. First of all, I found the mental nerve. I left here an old implant to use it. This is the mental nerve. And here I just go oblique in order to avoid the nerve. And after I did that, I just changed the angle of the implant so it will be parallel to the implant of 37. So it's great how it's done. Then I tried to put another implant. After that, I took it out. I just wanted to try, but it was but it was redundant, and just removed it afterwards. This is a temporary bridge, and this is the final result, my friends, 3 years after. Now you can see, and this works only for monolithic implants. You bend the implant and there is no bone loss Do you know why don't have a bone loss? Because you don't have the gap. This gap and the pressure creates all the problems. So another big case, upper case. Patient wanted only upper. Again, extracted all the upper teeth, put the implants, corrected the angles a little bit. This is the bridge, and this is how she looks. Now I want to show you a full movie to show you how it's done, a full case. Enjoy. This is the cortical implant, by the way. This is a closed sinus lift. Well, and in the last minutes, I would like to speak with you about the thing that I love most of all in my practice. And it's actually the digital age, because today I want to tell you that except from dentures, I don't use any materials for um, measures. That I don't use putty, I don't use wash, I don't use alginate, anything, only 3D. If I have to print a model, I print a model. I just don't use any more regular methods. Except for the fact that it gives me a very high accuracy. Here I have the option to give the patient with a print, to supply the patient with a printed bridge, full arch in 45 minutes. Because when we are using a printer, actually it's not by taking a piece and creating from that bridge. Here we just print the bridge. So one crown or one bridge actually takes the same time, 45 minutes. The patient gets that. So I will show you some cases, how it looks, how the temporaries look. I think that in 2020, I think that those who have a digital scanner will look in the eyes of the patient better than others. I want to tell you another thing. I didn't only save money for materials that I'm not using anymore. I save time, because if I had to have 3 meetings with the patient in order to give him a crown, here it takes me at least 1 meeting less. Only think how much money you can make when you save 1 meeting. So I think that this investment will return itself very, very fast in some few months. So here I have tooth number 13. I extracted the tooth. This is how it looks. Here you can see the extracted tooth. And here I'm putting the implant, as you can see, in order to bend it. So this is the angle, and this is the angle of the implant after bending it. This is how the scan looks. By the way, note, I don't have to take the full arch. I can take a third of an arch of the upper, third of the arch in the lower, and that's it. It is very accurate. Here you can see how does it look. By the way, this is 3Shape. For me, it's very comfortable. As you can see, it looks very detailed. And I want to tell you, this is in the day of the surgery. So just take into consideration that blood comes all the time. So it's very important to understand. So this is how it looks for the patient. The patient sees it directly in TV. This is the crown that I get 45 minutes after. I think I have this technology for 1 year, 1.5 years. I don't think I used acrylic at all. I don't even remember its smell. Just think about it. Working in a clinic without, and you know that the acrylic is harmful. So why to be exposed to it even? This is how it looks. It looks much better than any acrylic crown done in the lab. And that's just think, what do the patient think when he gets such a work? So this is the implant. Teeth 32 to 42. Here I did a pre-scan in order to show you. Here you can even copy the bridge as the original teeth if the patient insists to have it exactly the same. So these are the teeth. These are the implants. I changed the angle of the implant a little bit. This is how the implant look after changing the angle. Now you can see the impression. The impression is very clear. Here you can see the bite. The bite of the patient is taken as the original bite. And we can do a bridge that the patient and the technician can take into consideration how the original teeth of the patient looked like. So these are the implants. Another case, a little bit bigger, from teeth number 33 to 43. Here you can see the massive bone destruction. So, extracted the teeth, placed the implants, changed the angles a little bit, and then we did the impression. By the way, when you work digitally, you have the parallelometer in-house. You can see in green, in yellow, like a chart. You can see how much the implants are parallel one to another. And you can correct the angles of the implant accordingly. This is how it looks. You can see green, yellow, till I get the exact degrees. Here you can see it from above. And the bite. This is the bridge. This is how it looks 1 hour after. No mess with acrylic. Even I don't have to do bite corrections, just a little bit. It is very accurate. Another case, teeth 32 to 42. These are the implants. This is the bridge. Teeth number 23 to 25. This is the original bridge. These are the implants. This is the impression. See how it looks. See the resolution. Note the accuracy of it. Although you can see there that there is a blood when I do that. This is the bridge. This is how it looks. Quite nice for 1 hour after. Another case, teeth number 22 to 27. This is a very complicated case. So I extracted the teeth, removed all the inflammation, put the implants, corrected the angles. And this is the very nice thing. Here you can see how it looks. This is the temporary bridge. By the way, here you can see a pterygoid implant. This is also a kind of a long cortical implant. It is a very, very special implant for those cases. Another case, that this is a failing, these are failing implants after 10 years of service, something like that. Here, again, using only monolithic implants, bendable. Here you can see extractions of the teeth, putting the implants. At the day of the surgery, we do a digital scanning. This is how it looks, and this is the temporary bridge. Here you can see how it looks. Another case, here you can see a fistula actually that is going on. Now I want to tell you, in those cases, you just have to extract the teeth, to clean very well. The thing that you have to assure is when you do the drilling, not to take with you granular tissue inside. Otherwise, also the granular tissue will disappear. Because I believe that granular tissue, if it's not interfering with osteointegration, it has a whole potential in order to become even a bone. So here is how it looks. This is the impression. And this is the final bridge. So thank you for your attention. I'm sorry that I spoke too fast because I knew that this is my time limit. So this is the time for your questions.
We'll start with the first question. How can we intraorally trim the abutment? Won't there be too much of heat production?
Oh, this is what I exactly talking. I never do that with a diamond burr. I will always do that with a carbide burr. So carbide burr doesn't hit the bone. Now, if I have to trim it a little bit, I'll trim it. But if I have to trim a big part, I won't just remove, I'll cut, as you saw in the video. So it doesn't hit the implant at all. It was checked. It's with abundant amount of water cooling. And also the parts, the particles, the little particles of the titanium, also they do not interfere because we know that today we can use it also like bone substitute, that they merge into the material.
Thank you, doctor. Next question. Immediately loading implant for tooth with a periodontal lesion. Will it be successful?
Of course it will be successful because when I extract the tooth, I completely remove all the inflammation. Now, this is the place to say that when you remove all the inflammation, you have to also to assure that the adjacent teeth are also okay, so there will be no cross-contamination. Actually, I put the implant in a new bone, in a healthy bone. Of course, I add as much as possible bone substitute when needed, when the gap is bigger than 2 millimeters, and it will create no problem. By the way, in the literature, we find no difference between doing it immediately than doing it later.
Thank you, sir. For immediate extraction and placement without bone grafting, how will you cover jumping distance?
I always use bone substitutes in gaps bigger than 2 millimeters.
Thank you. In this system, anchorage is done on buccal or lingual cortical or perforating basal bone.
Oh, very good. Very good question. My thinking, as you could see in this lecture and in other lectures, I came from the area of basal implantation. So as much as I can, I try to use the basal bone and the anchorage always in the upper jaw, in the palatal part of the socket, because the buccal part of the socket is so thin that if you put the implant in this area, I can promise you that there will be bone loss.
Thank you. What are the complications faced during the placement during placing implants in the lower jaw?
First of all, you can break the neck of the implant if you are not too much experienced. For that, we have this special hex in order to take out the implant. This is the main complication that can happen when you are unexperienced or you drilled not enough. I think that if you use, for example, implant that is unbendable and you placed it in an incorrect angle, it will be very difficult, ranging to impossible to correct. These are the main complications, of course.
Thank you, doctor. I have few more questions. Can I ask them?
Yes, of course.
Thank you so much. In the posterior near sinus area, there is anchorage buccally or lingually.
Always palatinally, because it will always give you a stronger, and always the sinus in the buccal area is lower than in the palatal area, because it goes like that. It goes like a mountain. So it will always go in the palatal area. You will have a lot of place. And another thing, when you go oblique, it's like a triangle. The oblique line is always longer than any straight line that go 90 degrees to the other line.
Thank you. Is there any evidence as to there won't be any effect on fatigue fracture after bending?
No evidence at all, because if the bending it will be very extreme, more than 45 degrees, I think that yes. But I think that as to metallurgy, I think that it was designed the best in order to withstand it. I almost didn't see, and I did thousands, I almost didn't see fractures after bending.
Thank you. Should we have to mask the abutment prosthesis junction?
Should we have to?
Mask.
Should we have to when I do a scan?
So it's not mentioned, sir. I request Dr. Tarun Kumar, please reframe your question and resend it.
If he means in the 3D, I don't have to mask it when I use a 3Shape. 3Shape can read it without masking, if this is what he meant.
Thank you. Will the trimming create micro movement?
Very good question. I saw it. I saw it in the monitor. It will be very bad if there will be micro movement while trimming, because it means that the implant didn't get a sufficient primary stability. One very important condition is that the implant will have a very strong primary stability. If it moves while preparation, it means that the primary stability was not enough. Yes, it can happen, but it will always be a sign of an insufficient stability.
Thank you, sir. That was a wonderful answer. Next question. What about the gingival contour in the anterior area after rehabilitation?
This we can see in the literature, and this I can see after 22 years of working in extreme cases. When you don't open a flap, you extract the teeth, you immediately replace implants. In most cases, the papillas will stay as they are. This is the best chance to preserve the papillas. And it is, I'm not saying anything new. It's already known.
Thank you, sir. Next question. There are many studies which say that the failure rate in basal implants and immediate loading implants is severe. Do you still prefer one-piece basal implants, or would you prefer conventional implantology?
I do this and I do that. I think that 70% of my work still are regular implants. because the monolithic implants take me to cement-based restoration. Most of the restoration that I'm doing, I'm screw retained. I don't agree at all with the saying that this is an extreme or severe failure. From my experience and literature that I read, almost there is no difference between cemented and screw retained bridges over the years. And especially immediate loading, I think that is a very technique sensitive. If you isolate the cases of immediate loading that occlusion was done very, very gently and correct, I think that the failure rate is a little bit, of course, higher than conventional denture, or of course nothing to give the patient. But I think today you cannot give the patient after anterior teeth implantation a denture. It's a problem, especially among young people.
Last question.
Mm-hmm.
The same question, the masked one, he's reframed the question. The prosthesis seems to end above the neck of the implant. Won't there be any metal visibility of the neck of the implants? For that, should we mask with porcelain?
Very good questions. Yes, in these cases, we of course try to avoid it and place the implant, of course, deep enough. But yes, in these cases, of course, it will be masked by porcelain.